Hello, hello, hello. We're at our final module 5, and we're final lesson 2. Although you never know, I might do another lesson because if I get enough feedback from everyone, and if people tell me they want more of something, then there might be more. So you never know. But this time we are going to talk about the common rare side effects, strategies to deal with side effects, and kind of the risks of not taking hormone therapy. So, which I think is really important. Again, the disclaimer and disclosure, this course is not medical advice. It's educational. It's informational. So please take the education information you've gleaned here and use it for your benefit, whether it's just information that helps you to cope or whether it's something you're going to then take and go to see your own provider or give this information to a friend or a family member. That's great. I think that's all great. Just make sure that you communicate with your provider if you are having a lot of symptoms or experiencing problems, and or if you're just interested in talking more about hormone therapy. Okay. Reminder that I'm not affiliated with any drug or drug company or laboratory or any imaging company, and none of them are paying me. So this is just my own opinion from years of experience, also being a menopause certified provider, and myself having gone through a lot menopause. All right. And so the common side effects when you start on hormones, the most common thing is breast tenderness. And I don't know why I don't have this written down here. Irritability. A lot of women will say they are more irritable than before, and then the breast tenderness. And what I will say is just wait it out because it's just that initial surge. You haven't had this estrogen in your system for a while, and it's initial surge. Your body gets used to it, and usually within the first month, that side effect, breast tenderness and or increase in irritability, goes away almost always. Now, there are exceptions. You are an individual. Let's remember that. And you may be that person who is not going to do well on hormone therapy, or maybe the formula that you're being prescribed is not the right one. Maybe that patch isn't the right one. Maybe you're one of those patients who really does need compounded hormones to not have a lot of side effects. That's okay. That doesn't mean that there's anything wrong with you. It just means that, it just takes a little work to figure things out because you are an individual. Okay. But most women will do fine with the standard treatments here with the patch. Spotting or irregular bleeding is probably the other most common problem that we'll have in the first several months on hormone therapy. So I'm not too stressed out if someone's having some sort of spotting or staining or actual bleeding in the first 6 months. Of course, if it's heavy bleeding, then that's not okay. Anything that's heavy always needs to be evaluated. But if you're completely in menopause, been that way for more than 12 months, and you go on hormones and then you start to have some sort of bleeding, then we usually kind of wait it out. Maybe we adjust the dosing a little bit or make sure you're on the progesterone. A higher progesterone will control the bleeding usually, and then it shouldn't recur. Okay. If you're someone who has been on hasn't been on hormones and you're perimenopausal, going on hormones may stabilize your cycles. But if you're having frequent bleeding or bleeding in menopause, that's not normal. Okay. Okay. Oh, yes. And with the breast tenderness goes like bloating, right? Fluid retention. That's probably big reason for the breast tenderness. So all that will resolve. And again, we may have to start the progesterone sometimes to counter some of those estrogenic effects or lower the estrogen dose for a while. We'll talk about that in another slide in a second. So rare but serious side effects. Thromboembolic events. We talked about that before, the venous thromboembolism risk, thromboembolic events, DVT, deep vein thrombosis, pulmonary embolus, stroke, and sometimes even heart attacks can happen. That's, so just to be aware that is very rare. But this is why we're cautious about who we start on hormones. If someone's got uncontrolled high blood pressure, someone has a history of a DVT or a PE, or someone has uncontrolled cholesterol problems, then they may already have a lot of plaque, and starting the estrogen might kind of trigger something in the blood vessels, and so you want to be cautious. So it's not necessarily for everyone, or you may need to just start on a very low dose, depending on your history. Gallstones. Remember we talked about gallstones being more common in that perimenopause time when you have that estrogen that's higher with not as much over the progesterone. And so the concentration inside the gallbladder, the bile concentration gets higher and forms stones. So that is also a risk when you first start on estrogen. So just something to be aware of. It's not a common thing. Again, it's rare. But if you end up developing gallstones, you may have to have surgery and remove the gallbladder. So that can be serious. More common, I do see migraines or worsening headaches do happen. And that's usually in the phase of when things are stabilizing. And I feel like with most patients, that ends up evening out and the headaches get less frequent. So I think that needs patience, but it should improve. All right. I just want to mention about migraines is that if someone is having migraines with aura, it's known that we don't put those patients on birth control pills because there's a concern about an increased risk for stroke. So we would be kind of aware of if a patient has migraines with aura, even though there's no data with the hormone therapy, that's menopausal hormone therapy, we want to just be aware and maybe, again, start on a lower dose. Okay, so coping strategies for the side effects, like the breast tenderness, the bloating, the irritability. I usually say to wait it out a little bit, but we can also certainly lower the dose if that's possible. So if we just started on an estrogen patch and for whatever reason let's say we started on a 0.05, I might have the patient for a couple of weeks. This is not official. You didn't hear me say this. Cut off a little piece of the patch and make it a little lower dose. Rather than sending in a whole different prescription, the patches are kind of trimmable, so you can cut off a little bit of it and lower the dose a little bit for a couple of weeks and then maybe go back up. Another option, of course, if the patients was started out on an oral, switching to transdermal or a vaginal route, depending on what the indication, what the need is for that patient to be on estrogen. And of course, just monitor and reassess. And with my patients, I usually just say, let me know if you're having really horrible symptoms, but here's the most common things that I'm not concerned about, and they're usually going to go away. And otherwise, I don't need to hear from you for 2 to 3 months. Okay, this is the important thing. And this is what I think every single woman should be asking and every single provider should be asking. Okay, this is the heart of the matter. What is the risk of not taking hormone therapy in menopause or even in perimenopause? What's the risk of not taking it, right? We're going to have a higher risk of osteoporosis and fractures. So you're going to start losing bone density when you're perimenopausal. And then that will continue into menopause. And having osteoporosis increases your risk of a bone fracture if you fall. And actually, there's a high risk of mortality, dying, in the first year after a hip fracture. So we really want to prevent osteoporosis. This is one of those things that is preventable. So this is one of those things, if you think about what is the risk of not taking hormone therapy, this is a big risk. Not taking hormone therapy, you risk developing osteoporosis and eventually having a fracture, hip fracture, or other fracture. Okay, what is the cardiovascular risk of not taking hormones? If you are just in perimenopause or just barely into menopause, There is strong data that hormone therapy, estrogen therapy, reduces that buildup, reduces the chances of developing atherosclerosis, reduces lipid changes, or improves your lipid profile, your lipid panel. So there is strong evidence that hormone therapy in women who are recently in menopause is going to reduce the risk of cardiovascular disease. Okay. It's not yet to the point where the FDA or the CDC or the US Preventive Task Force is recommending these medications for that purpose. They're going to have to do a lot of studies to get it specifically recommended that way. It takes a long time. We just got the black box warning off of estrogen, scaring people about that everyone needs to worry about having a blood clot. Okay. But the data is so convincing, and that's a risk of not taking hormones, is that you're going to allow your body, when you could have prevented cardiovascular disease, you're going to allow your body to develop cardiovascular disease. And what do women die of in this country besides cancer? Cancer is the second biggest killer of women, second or third. Women die of heart attacks, heart disease, or cardiovascular disease. That's number one, and then cancer. So we want to prevent vascular disease. We want to prevent the buildup, the damage. And remember, what did estrogen do? It has anti-inflammatory effect. It improves the flexibility of blood vessels by encouraging the release of nitric oxide. There were other, improves the lipid panel, so you're less likely to build up plaque. It's not 100% reducing your risk, but it may be slowing the process down. That's why women have a later risk of developing heart disease, right? Men develop heart disease sooner than women do because estrogen has that protective effect during our menstrual years. And by continuing hormone therapy, you're going to continue to reduce that risk. That's my opinion. I am not going to start someone on it who's far too into menopause, because by then their body has already developed plaques and atherosclerosis. But this is a preventive measure. Okay. And again, I'm going to say this again. The US Preventive Task Force is not recommending it. The CDC is not recommending it. The Menopause Society put out a statement saying they can't recommend it for everyone because it depends on how old you are and your other risk factors. So, and that is true. So if I saw someone who is 45, but they already have significant high blood pressure again, and they already are on a statin for their cholesterol, I'm not sure if hormone therapy is going to be beneficial for someone in that category, like someone like that. Okay. What are we preventing? We're preventing urogenital atrophy or genitourinary syndrome of menopause. By preventing that, we're preventing recurrent urine infections, vaginal infections. We're preventing painful intercourse. I just think also in the long run, we're preventing, hospital admissions for urinary urosepsis. So taking hormones is preventive for your genital area. Okay? And if you're continuing to be sexually active, the risk of not using estrogen, even if it's just a vaginal estrogen, the risk of not using it is that you will potentially develop, not everyone, but you may potentially develop difficulty having intercourse or difficulty enjoying intercourse. Okay. Quality of life. The risk of not taking hormones is that you continue to have sleep problems, irritability, cognition, because you're having the brain fog. And this also doesn't impact just you personally and your life, your career, your job, but also it can impact your relationships. So that's a risk of not taking hormones. Okay. Remember, we did talk about other options. So those other options could target some of these symptoms. You could target the mood and the night sweats separately, and then separately deal with sleep, and separately, deal with each problem. But we're looking for something that's going to help everything. All right, you may be missing out by not taking hormones on preventing dementia. So there's new data showing that estrogen may prevent dementia. So the data isn't great, so it's not a strong recommendation. Um, More important is to keep your blood pressure well controlled, which might be how estrogen is helping. Okay, because estrogen helps to lower your blood pressure. Estrogen helps to better cholesterol profile. So, and having a worse cholesterol profile and higher blood pressure increases risk for dementia. So, it might not be a direct impact of estrogen, but there's data showing that taking estrogen reduces the risk for dementia. It's not a strong recommendation at this point, but it's there. So I want to make sure you're aware of that. And you would be missing the opportunity to reduce your colon cancer risk. Remember, we talked about that patients who were on estrogen reduced their colon cancer risk by 20 to 40%. And there's some data showing that there's a reduction in breast cancer risk. So, actually, from the Women's Health Initiative study, the women who took estrogen alone had a lower rate of breast cancer. And with the newer formulations with the micronized progesterone, there's some data showing a potential lowering of breast cancer risk. So it's pretty, it's not 100% clear, but you're missing out on colon cancer reduction, and and possibly breast cancer reduction. So these are big things. Again, and that's not the total reason to go on hormones. The reason we prescribe hormones, I want to make sure this is very clear that the reason to prescribe hormones, the main reason is for your symptoms, right? Perimenopausal and menopausal symptoms that we talked about extensively, that every person might have different symptoms, but that's the best treatment for those symptoms if you're eligible, if you don't have a contraindication. But these are extra things that you might be missing out of. There might be a risk of not taking hormones. So I want patients to keep that in mind. I didn't address in this whole series, I really didn't talk about women who have had breast cancer. I want to make sure I remind you, I did talk about that if you have a family history of breast cancer, and then it's still okay. It actually is safe to take hormone therapy, and it's not contraindicated. And again, there may be a reduction in the risk. BRCA gene, if you have a gene, then I can't really say that. I probably would hesitate if someone has a gene mutation, and probably if you're a patient with gene mutation, you probably would hesitate as well. But keep in mind, always, no matter what else is going on in your health, this is for everyone. Everything is about a risk benefit ratio. You're always going to balance, like, okay, I'm worried about this. This is a health concern, but this is really the pressing problem for me, and I have to feel better. So it really is going to depend on you, and you having those conversations with your provider and coming up with a plan. And so someone who has a BRCA gene, but is really suffering in perimenopause, may say, look, I'm doing, really careful surveillance, or, I want to take hormones for a few months just to get some relief. I don't know. I've never had such a patient, but I'm just saying that every person's an individual. So just keep that in mind. I also, I want to talk about also patients who might have had breast cancer. And I mentioned it at one point, but there are some studies showing that even if you've had breast cancer, particularly very early breast cancers, like stage 0 breast cancers, then when you've completed your 5 years of anti-hormone therapy, you could be eligible to take hormone therapy for your symptoms. So I want to make sure that we are aware, because if 1 in 8 women in this country are going to get breast cancer, and a number of them are younger, we need to have that better data on it. But those women, after 5 years, after they've finished their anti-hormone therapy, may be able to take hormones for symptoms. Okay. But that is very individually based. Okay. That's not necessarily a generalization, it's very individually based. Be aware that most breast cancers are not at a younger age, they're at an older age. So, by that point, let's say you get diagnosed with a breast cancer at the age of 80, um, if you have to stop hormone therapy, these other benefits you've already benefited, right? You've already benefited by the age of 80 from the reduction in cardiovascular disease or the prevention of osteoporosis or prevention of urogenital atrophy. So you may have to stop hormones, but don't not take hormones because you're afraid at the age of 80 you're going to get cancer, a breast cancer or some other cancer, because the data seems to show that it doesn't increase and it might decrease your risk. Okay. Balancing benefits and risks, I kind of keep talking about it. Everything should be individualized. Decision making should be between a patient, you, the patient, and your provider. If you don't have a provider who seems knowledgeable or they poo poo your concerns, then you're not seeing the right person. You just need to find the right person. But don't let them get you down, okay? Because you know what's going on with you and you know your symptoms are real and there's something going on and you need to feel better. Okay? So don't let them get you down. If you encounter someone who doesn't know what to do or doesn't think it's related to perimenopause or menopause, just say, okay, I know I'm gonna find someone else. It's okay. It will be okay. I know it's hard when you're in that moment, and given that a lot of times we have a lot of more mood symptoms, so it's hard not to get emotional in that situation, but it's going to be okay, really is. So just be positive, and it will happen. I'm a big positivity person. Like, I say positive affirmations before I go to bed and don't want to go to sleep with anything negative in my head, and um, try to stay positive, and not let things stress me out during the day unless it's something related to being late with my kids to someplace. I hope you don't mind I'm sharing that. Okay, so shared decision making, monitoring the benefits and side effects over time. So just because you benefited from going on hormone therapy at the age of 50, maybe it's not right for you anymore, at 65. Maybe at that point, first of all, maybe new information comes out that the better formulation to be on is something else, or you really should be on a different dose to benefit the most. Or maybe we come out with some sort of data that says 10 or 15 years is the limit. Right now, there isn't a limit of amount of time to be on hormones. That's an old school thing. There used to be a limit. Now there isn't a limit. So maybe that will change again. So it is important to keep connected with your provider who is informed, and not just, just to make sure and ask, is there any new information I need to know about on an annual basis when you go in to touch base and get your prescription refilled once you're on that stable dose. So here, keep in mind the benefit of taking hormone therapy for long-term disease prevention, whether it's cardiovascular disease, cancer risk, dementia, or bone health, might be also multifactorial. So it might just depend on your age, when you start on hormone therapy, your prior medical history, your family history, etc. So again, you're an individual. I can't, tell you from taking this course, you've taken this course and now you're going to walk in and say, I want to be on this, and this. You could say, you want to start on the average dose, like a 0.05 patch, or you want to start on a 0.0375, a little lower, and see how you're doing after a few months. And, we can go up to all the way up to 0.1. Very few people are on I have on 0.1 personally, but you could do that. But you could also go talk to someone who's experienced and see what they have to say. The thing I want to make sure that going into that situation is a lot of providers don't know all the different options. I literally, this past week, went for, met up with a friend of mine who's an OBGYN, and she herself was using patches and they weren't staying on very well. And I said, well, why don't you just switch to Divigel, the gel, or the mist? And she didn't even know that they existed. So by taking this course, you have so much information that a lot of even OBGYNs don't have. And certainly a lot of primary care providers don't have, and other providers. So you have all this information, and there are options, there are FDA approved prescription options that your insurance will cover. Yes, you have to pay a copay, but in the long run, if you're staying on hormones for 30 years potentially, you want to try and find something that's not going to be too expensive, and you want to stay knowledgeable. Like every year, there might be something new that comes out, or you want to touch base, about, yeah, is there a new study, or should you change your dose, So it is going to be important to find someone, not only to stay educated and informed, but to find someone who is knowledgeable, so that they're best able to help you. I do think that's changing. I think it's coming around, and I think you're going to find over the next few years that more and more, even primary care doctors, are more informed about options for you. So, okay. Well, we're going to summarize here. I think that was a great summary for this whole course. Um, and, you can read the slide here: common side effects, breast tenderness, bloating, spotting, rare things, thromboembolism, gallstones, and migraines, coping with side effects, dose adjustment, route change. So from, maybe oral to something else. Maybe you want to do the fem ring, which isn't used that often, and monitoring your symptoms. And not using hormone therapy carries significant health risks for some women. So just keep that in mind. Um, I wanted to mention one other thing. When you're prescribed a brand prescription, if there is no generic, always look, this is not just for hormone therapy, for everything, always look for a coupon on the manufacturer's website. So you go onto, let's say, FemRing, and you can search, the company name, or type in FemRing coupon and see if there's a coupon out there to help pay for it. So I think that that's actually very helpful. I want to make sure you know about that. And also, there's another thing that can help lower your cost called GoodRx. That's another. So there's all sorts of new things coming out to help you lower your cost. And so if you stay with those FDA approved treatments that you get from a regular pharmacy, which is what I try to do for patients, it will most often be less expensive in the long run. Another thing to keep in mind is the IUD is usually covered at 100% by insurance, even though you're not using it for birth control, because it's just coded as IUD insertion. And so think about getting an IUD to protect the lining of the uterus instead of having to take an oral progesterone. There's so much information, so many options. I look forward to hearing from all of you, any comments once you've completed the course, and I'll be happy to add more modules if it seems like there's a need for maybe more case examples, if that's something that people end up wanting. And I've enjoyed giving this course to you. I really hope that you're able to use this, and let me know how it goes. Okay. All right. Good luck and take care. Bye-bye.